Alright, this is Pack 365, myself Sreja. So today in this video, in this session, you are going to learn about the ICD-10-CM coding guidelines for certain infectious and parasitic diseases. So this coding guidelines falls under Chapter 1 of ICD-10-CM coding book. So what are the guidelines for certain infectious and parasitic diseases? So these guidelines, the codes ranges from A00 to B99, and as well as there are some added codes U07.1 and U09.9. So let's look into a guidelines regarding HIV infection. So how do you code in the cases of HIV? So you have to code only confirmed cases of HIV. So ICD-10-CM says code HIV only when it is confirmed, but confirmation does not require the lab results. So this is one of the few exceptions in ICD-10-CM where provided documentation alone is enough. So what counts as confirmed? So if the provider writes HIV positive, HIV infection, HIV disease, AIDS, HIV related condition, so you can only code it as confirmed even if lab tests are not mentioned. So what does not count here? Rule out HIV or patient tested for HIV or possible HIV. So these are not coded as HIV. So what is the important point? ICD-10 uses the code Z21 for asymptomatic HIV infection. But this is used only when the provider states HIV positive or HIV infection and specifically says the patient has no symptoms or HIV related conditions. So you have to code only confirmed cases of HIV. So never code undoubtful cases. So next is selection and sequencing of HIV codes. So how do you select? How do you sequence them? So what is first? Patient admitted for HIV related condition. So what is the key rule for sequencing? If a patient is admitted because of an HIV related illness, so the principal diagnosis must be B20 for HIV disease. So not Z21 or not R75, which is inconclusive. So then you have to add codes for opportunistic infections, HIV related cancers and other complications caused by HIV. So what are the common HIV related conditions? It may be Kaposi sarcoma, which you have to code C46, candidiasis of mouth or esophagus, B37.0 code or B37.81. So once the patient has any HIV related condition, so they are always coded with B20 for life. So even if the provider writes HIV positive, once B20 is assigned, never go back to Z21. So what is the exception here? Hemolytic uremic syndrome, which is called as HUS, due to HIV. So if the patient is admitted for infection associated HUS, which is a rare but severe condition, so the sequencing is different. So what is the correct sequence? B59.31, for which you have to assign the infection associated hemolytic uremic syndrome, followed by B20, which you will assign for HIV disease. So why this is an exception? Because ICD-10 guidelines state that HUS should be listed first as a principal diagnosis when it is the primary reason for admission. So even if the HIV is the underlying cause. So provided documentation, it controls coding. So labs are not required to code HIV. Providers' words are enough. So never use Z21 once B20 has ever been assigned. So because the patient has already progressed to AIDS or HIV disease. So next is patient with MIV disease admitted for unrelated condition. So what is the key rule? If a patient already has HIV disease B20, but it is admitted for something that which is not related to HIV. So then what is the principal diagnosis over here? The unrelated condition. For example, fracture, pregnancy, appendicitis, motor vehicle accident injuries. So what is the secondary diagnosis? B20. So because the patient has HIV disease. So what are the additional codes? You have to add HIV related conditions, if any, but only if they are treated or affect the care. Right. So when taking an example, like when patient with HIV disease comes for treatment of a wrist fracture after a fall. So principal diagnosis, you have to assign S52.501A code, which describes unspecified fracture of the wrist. And the secondary diagnosis is B20 for HIV disease. So any other HIV related conditions if present. So second example is if HIV patient admitted for gallstones which are not caused by HIV. So the principal diagnosis is calculus of gallbladder, nothing but K80.20. So here HIV patient, but he has admitted for gallstones. So the encounter for visit is gallstones. So these gallstones, they are not caused by HIV. So that is why B20 is added as an additional diagnosis but not as a principal one. So students often confuse this rule with patients admitted for HIV related problems. So if the reason for admission is HIV related, so B20 is principal. If the reason is not related, the condition is principal and B20 is secondary. So third guideline is whether the patient is newly diagnosed. So it does not matter. So if it does not change the sequencing. So whether the patient just found out they have HIV, has had HIV for 4 years, or has frequently any visits for HIV. So sequencing rules stay the same. The focus is always on why the patient is being admitted. For example, a newly diagnosed HIV patient is admitted for pneumocystis pneumonia. So even though the HIV is new, so this is an HIV related condition. So B20 must be principal. B20 must be assigned as a principal diagnosis code. So fourth guideline is asymptomatic HIV infection. Z21. So when to use Z21? Asymptomatic HIV infection status only when the provider states HIV positive, HIV infection, known HIV and HIV test positive. So and the patient has no symptoms, no opportunistic infections or no HIV related conditions. So when not to use Z21? When provider uses terms like AIDS, HIV disease, HIV with or HIV related, or you have to use B20 instead. So if patient has any HIV related condition, examples like oral thrush, Kaposi's sarcoma, HIV encephalopathy, CNV infection, so this automatically convert the patient to B20. So there is a very important coding rule is once a patient is assigned B20, HIV disease, so they always remain B20 for life. Even later they appear healthy. So you should never return to Z21. So example is asymptomatic HIV. So patient is HIV positive. So there are no HIV symptoms. So which code you have to assign? Z21 because he is just positive. He does not have any symptoms. So asymptomatic HIV, always you have to code Z21. So what are the key points over here? HIV related means B20 principal. Not related, other condition is the principal diagnosis and B20 is the secondary. So if it is a asymptomatic HIV, you have to assign Z21. Only Z21 but not B20. So if in cases of inconclusive test, you have to assign R75. So reinforce lifetime rule. Once B20, always a B20. So always use real life scenarios and you have to identify, is it related to HIV? Is the patient asymptomatic? So which code becomes principal? So you have to question yourself while coding with conditions related to B20 and Z21. So E guideline, patients with inconclusive HIV serology. So what does inconclusive HIV serology mean? The patient had an HIV test. So results were not clearly positive or negative. So there are no symptoms of HIV. There is no confirmed diagnosis yet. So what is the code to assign? R75, inconclusive laboratory evidence of HIV. So this code is used only temporarily until confirmatory testing is done. So what is a teaching example? Patient tested for HIV, ELISA is positive, but Western blot is indeterminate. There are no HIV symptoms. So what is the code you have to assign? R75. So you should not assign Z21 because the patient is not confirmed HIV positive. And you should not assign B20 because there are no HIV related conditions, right? So this is about the E guideline. So next coming to F, previously diagnosed HIV related illness. So this is fundamentally important in HIV coding. So what is the rule 1? If a patient has ever had an HIV related illness, so you have to always code B20. So this is for life. Even if the patient is currently healthy, the HIV illness occurred years ago or they look asymptomatic now. So what is the second rule? Never switch back to Z21 or R75. So once B20 has been assigned for HIV disease or AIDS, so you should never code Z21 or never code R75. So because the patient is no longer asymptomatic. So what are the examples of HIV related illness? Pneumocystis pneumonia, HIV wasting syndrome, Kaposi's sarcoma. So any of these, B20 is forever. So next guideline, HIV infection in pregnancy, childbirth and puerperium. So how should you code for HIV infection in the cases of pregnancy? So what is a special rule? You have to always start with an O code in any of the obstetric cases. So what is the principal diagnosis? O98.7 series. Nothing but they are HIV complicating pregnancy, childbirth or puerperium. So next you have to add B20 or Z21 depending upon the patient's HIV status. So if a patient has HIV disease or AIDS or HIV related conditions, you have to assign B20 along with the O series code. If the patient is asymptomatic HIV positive, you have to assign the code Z21 along with the principal diagnosis O codes. So then add codes for any related HIV related illness. So if the patient has any other infections which are related to HIV, then you have to add them as a third code. So for example, if a pregnant woman presents for routine care, so provider states HIV positive but it is asymptomatic. So you have to assign two codes, one for obstetric case. So O98.71 for HIV complicating pregnancy and Z21 is asymptomatic HIV because there are no symptoms at all. So what are the common mistakes generally people do? You have using Z21 for a patient who previously had a HIV related illness. It is wrong. So you have to use B20 always. And some people use assigning B20 just because the HIV test was positive. No, if B20 you have to assign when a test is positive and he had a HIV related illness. Here there is no HIV related illness. It is only just positive. Then you have to assign only Z21 because there are no even symptoms or conditions. So next code is, so codes from chapter 15, pregnancy, childbirth and puerperium take priority. So what does this mean? If the patient is pregnant, giving birth or the patient is in the postpartum period. So OB codes must be sequenced first always. Why? Because ICD-10-CM insists that if any pregnancy impacts the care or is impacted by the condition, O code takes it or outrank all the others. For example, if a pregnant woman comes in for HIV testing, you have to use obstetric code case first. So first the principal case would be O series code, then you have to assign either Z21 or B20 depending upon the HIV status. So if a patient with asymptomatic HIV during pregnancy, so what would you code? If a pregnancy patient is HIV positive but she is asymptomatic, then you have to assign O98.71 code which describes the HIV complicating pregnancy and Z21 for asymptomatic HIV infection status. So this rule applies for pregnancy, childbirth as well as postpartum. So what are the encounters? So H guideline is encounters for testing for HIV. So this section explains how to code test, not diagnosis. So this is an important because generally people confuse HIV testing versus HIV status. So what is the first guideline? Patient comes only to determine the HIV status. So you have to use Z11.4. So this is the encounter for screening for HIV. So you have to use this code whenever a patient is getting a routine test. There are no symptoms, no exposure and no diagnosis. It's a general routine test. So you have to add additional codes if needed. For high risk behavior Z72.5 or for counseling Z71.7. So there's an example. A patient wants HIV screening as a part of routine annual physical. So you have to assign the code Z11.4. So second guideline is patient has signs or symptoms and is being tested. So if a patient has symptoms, for example, like fever, weight loss, swollen glands and doctor orders HIV test. So you have to code the symptoms first. Then the HIV counseling happened during visit. You have to give the code regarding the visit. So you do not use Z11.4 because the encounter is no longer right. It is no longer routine. So if a diagnostic testing driven by symptoms, you have to assign the code Z71.7. So next guideline is patient returns to get results. HIV test negative. So if a patient comes back just to get results and the HIV result is negative. So in these cases, you have to assign the code Z71.7 for HIV counseling. There is no test done here. So HIV result is also negative. So you have to assign the code regarding HIV counseling. Since the test is done, no diagnosis is made and patient is receiving counseling about the results. So for example, patient previously tested for HIV. So now he returns to here negative results. So in this case, you have to code Z71.7. So if the HIV test is positive, so how would you code? So you must decide between again Z21 if it is asymptomatic HIV, B20 if it is HIV related condition, and R75 it is inconclusive. So follow all the earlier rules for confirmed HIV versus HIV disease. So next guideline I is about HIV managed by antiretroviral medication. So what does this mean? This patient has documented HIV disease or HIV related illness. So how would you code? The first point is you have to assign B20 for HIV disease because anyone on antiretroviral therapy is considered to have an HIV disease even if symptoms are controlled. So then the second code is you have to assign Z79.899 for long-term drug therapy. So this code indicates the patient is on long-term medications. For HIV patients on ART, so this is very important. So patient with HIV disease stable on antiretroviral medications, you have to code B20 and Z79.899 long-term drug therapy. So students may mistakenly think asymptomatic HIV patients on ART should be coded Z21. So this is incorrect. You have to code only B20 because antiretroviral medication is nothing but it's a medical management of HIV disease. So this is about I guideline. So next is Z, encounter for HIV prophylaxis measures. So what is prophylaxis measures? So pre-exposure prophylaxis, PrEP. It is a medication given to people without HIV to prevent infection. So example like a person with high sexual risk, partner of an HIV positive person, or people who inject drugs. So what is the principal code for PrEP result or PrEP visit? You have to assign the code Z29.81 for encounter for HIV pre-exposure prophylaxis. So you have to use this when the patient comes specifically to start PRP, to continue PrEP, to refill PrEP medications, or to get the monitoring labs for PrEP. So what are the coding rules for PrEP visits? If risk factors exist, you have to code them too. So example like Z72.5 for high-risk sexual behavior, F11.10 for opioid use, Z20.6 contact with no exposure or exposure to HIV. So you should not use B20 or Z21. So because the patient does not have HIV. So if we take an example like patient visits clinic for PrEP refill, there is no HIV. So which code you have to assign? Z29.81 code. So this is about the encounter for HIV prophylaxis measures. So next guidelines are related to infectious agents as the cause of diseases classified to other chapters or diseases classified elsewhere. So this section explains a general rule for infection. Sometimes the main diagnosis is in another chapter. For example, like in the respiratory diseases or in the digestive diseases or skin related. But the organism causing it must still be coded. So you have to add a code from chapter 1 to identify the organism. So these are the organism codes such as B95 streptococcus, B96 other bacterial agents, B97 viral agents, and B20 for HIV. So how do you code the infectious agents? So why these codes are used? Because sometimes the main diagnosis is in the another chapter. So the diagnosis does not mention the organism. So when the provider says which organism caused the infection, you must add an additional organism code. So organism code ranges are B95 for streptococcus, staphylococcus, and enterococcus. B96 for other bacterial agents, and B97 are for viral agents. So these codes, they cannot be used alone. So they are added to the main infection code. For example, pneumonia due to Staphylococcus aureus. So you have to assign the code Z15.2 for pneumonia due to Staphylococcus and B95.6 Staphylococcus aureus as an case. So how do I know when to add B95 to B97? So this is a major doubt, like generally people do. So if the infection code does not include the organism, you have to add the code B95 and B97. So if the infection code already specifies the organism, then you should not add the B95 to B97 code categories. So you will see instructions such as use additional code to identify organism or code first the underlying infection. So these tell you the infection is the primary diagnosis, the organism code is secondary. So you have to always read the instruction notes which are present in the tabular section. So section C, infections resistant to antibiotics. What does this mean? Some infections become hard to treat because the bacteria do not respond to the usual antibiotics. So for example, like MRSA, methicillin resistant Staphylococcus aureus, and VRE, vancomycin resistant enterococcus, and multi-drug resistant tuberculosis. So when to use this Z16 codes? You have to use Z16 for resistant to antimicrobial drugs only when the provider states the infection is drug resistant and the infection code does not already specify the resistance. So there is an example. The diagnosis shows you urinary tract infection caused by E. coli resistant to penicillin. So which codes you have to assign? The first code for UTI, urinary tract infection, N39.0, and the secondary code E. coli as the cause. So B96.20 and Z16.10, which is a resistant to penicillin. So generally people incorrectly use Z16 when the infection itself already identifies the resistance. So if resistance is already in the infection code, you should not add the Z16 as the another code. So the next section is sepsis, severe sepsis and septic shock. So this is a high important topic in ICD-10-CM. So how do you code the sepsis and severe sepsis? So for sepsis, you have to code the underlying systemic infection first. So this is a general rule and the important rule. So if there is a sepsis due to E. coli, so you have to assign the code A41.51. So there is an example like there is a diagnosis in the record like sepsis due to streptococcus. So which code you have to assign? A40.9, the streptococcal sepsis. So there is no need to add B95 because A40 already includes the organism, right? So this is how you have to code sepsis and severe sepsis. So when provider documents the severe sepsis, so if it is severe sepsis, two codes are required. So the underlying infection first, A40 to A41 series, and then R65.20 if it is severe sepsis without shock, or R65.21 it is severe sepsis with septic shock. So what is an example? Severe sepsis due to E. coli with acute renal failure. So there are three codes which you have to assign. A41.51 for E. coli sepsis, R65.20 for severe sepsis, and N70.9 for acute kidney failure or renal failure. So there is another guideline for septic shock. So if septic shock is documented, you have to code the infection first. Then R65.21 for severe sepsis with septic shock. So then if there are any acute organ dysfunction codes, you can add them. So when a type of infection of organism is not specified, so how do you code? What is the guideline? If the type of infection or causal organism is not further specified, you have to assign the code A41.9 for sepsis unspecified organism. So sometimes a provider simply documents sepsis with no mention of which organism caused it, either a bacteria, virus or fungus. So what type of infection caused it? So in those cases, you have to use A41.9 for sepsis unspecified. So what is the diagnosis? If the patient admitted with sepsis, you have to assign the code A41.9. So then next is R65.2, severe sepsis. in which the code should not be assigned unless documented. So what is the guideline for this one? You should not assign R65.2 unless a severe sepsis or acute organ dysfunction is documented. So to code severe sepsis, you must have sepsis and acute organ dysfunction. So without organ dysfunction, you should not assign the sepsis code R65.20 or R65.21. So there is an example. A diagnosis is severe sepsis with acute respiratory failure. So you have to assign the code for sepsis, severe sepsis, and as well as the acute respiratory failure. So next guideline is negative or inconclusive blood cultures and sepsis. So negative or inconclusive blood cultures, they do not rule out sepsis. If clinical evidence is present, the provider may need it to be acquired. So sepsis is a clinical diagnosis. So it is not just based upon the blood culture. So a patient may have fever, hypotension, elevated lactate, tachycardia, and organ failure. So all of this can meet sepsis criteria even with the negative cultures. So what is the example? The diagnosis is sepsis blood cultures negative. So you have to code as sepsis A41 because clinical criteria support it. So when to query the provider? If the note only says rule out sepsis or possible sepsis, if the clarification is required. So next is urosepsis. So the term urosepsis is non-specific and it is not considered synonymous with sepsis. So it has no default code in ICD-10-CM provider must be acquired. So urosepsis, it is an ambiguous term. So it could mean UTI, pyelonephritis and sepsis from urinary source. So ICD-10, it does not allow a default code because it is unclear. So what you have to query? The provider should clarify whether they mean sepsis due to urinary infection or UTI only, or it is a systemic infection. So provider must specify the organism as well as the severity. So what is an example? Patient presents with urosepsis. So do you mean sepsis, UTI or pyelonephritis? So this is how you have to query the provider. So fifth guideline is sepsis with organ dysfunction. So if a patient has sepsis and as well as acute organ dysfunction, so you have to follow the instructions for coding severe sepsis. So when organ dysfunction is documented, the case becomes severe sepsis. So you must code the underlying infection, so A40 to A41 series, and then severe sepsis without shock or with shock, and then followed by the organ dysfunction code such as acute kidney failure, respiratory failure, etc. So there is an example. There is a diagnosis like sepsis due to E. coli with acute kidney failure. So you have to assign three codes: A41.51 sepsis due to E. coli, R65.20 to severe sepsis, and N17.94 acute kidney failure. So next is acute organ dysfunction that is not clearly associated with the sepsis. So if a patient has sepsis plus acute organ dysfunction, but the provider documents that organ dysfunction is caused by another condition but not the sepsis, so you should not assign R65.2. So to assign severe sepsis, the organ dysfunction must be directly linked to the sepsis. If the documentation is unclear, you have to query the provider. So ICD-10 requires sepsis confirmed and organ dysfunction caused by the sepsis but not other condition. So there is an example. If organ dysfunction not related to sepsis, it is documented as sepsis, acute kidney failure due to dehydration. So the acute kidney infection, it is not caused by sepsis. So you have to code A41.X for sepsis and N17.9 for acute kidney failure. So next is severe sepsis. So for severe sepsis, it requires coding. Coding requires minimum two codes. The first code is underlying infection. The second code is severe sepsis code with or without shock. So if the organism is not known, you have to use the A41.9 sepsis unspecified organism because it doesn't given the organism name. So always assign the additional codes for each acute organ dysfunction. So some cases require provider query because severe sepsis is complex. So always remember, when you have to code severe sepsis, you need three things to be confirmed: sepsis, organ dysfunction, and clear link between sepsis, which is an organ dysfunction. And what are the required codes? Underlying condition or underlying infection. For example, like A40.0 sepsis due to streptococcus, A41.9 sepsis unspecified organism. So if the organism is not documented, you have to use A41.9. And R65.2, it is code for severe sepsis without septic shock or severe sepsis with septic shock. So what is the organ dysfunction codes? Acute kidney failure for N17.9, acute respiratory failure for Z96.00, and encephalopathy for Z93.40. These are the ICD codes for the organ dysfunctions. These are some of the examples of the codes. So next, coming to septic shock. So what is septic shock? It is a more severe form of sepsis. So it occurs when severe sepsis causes major circulatory failure, meaning the patient's blood pressure drops dangerously low. So because circulation fails, septic shock is considered a type of acute organ dysfunction. So you have to think of sepsis as a ladder. So the infection, for example, pneumonia, and sepsis, infection plus systemic inflammation, and severe sepsis, infection plus organ dysfunction, and septic shock, severe sepsis plus circulatory collapse. So septic shock is always the top level, the most serious one. So ICD-10-CM coding rules for septic shock. So how are the guidelines? How are the coding rules? So first is code the underlying infection first. So this infection is a principal diagnosis, right? So for example, A41.9 sepsis unspecified or A41.51 sepsis due to E. coli. So second rule is to then assign R65.2 severe sepsis with septic shock. So then add codes for other acute organ dysfunctions if they are present. So what is the sequencing of severe sepsis? So case 1, severe sepsis is present on admission. So how do you code? So the underlying systemic infection is coded first, which is the principal diagnosis. So then you have to assign R65.2, which is for severe sepsis, plus any organ dysfunction codes. So you have to code from R65.2, can never be a principal diagnosis. So the case 2 is severe sepsis develops after admission. So if the patient did not have severe sepsis at the time of admission, the underlying infection is still principal diagnosis. So the severe sepsis is R65.2, which becomes a secondary diagnosis. So principal diagnosis is always the infection. It is not R65.2 or R65.21. So think of R65.2, which codes as severity indicators, not diseases. So they must follow an infection. So septic shock is never sequenced as a principal because it is a manifestation, but not the primary disease. So always check whether the severe sepsis was present on admission. So this affects the sequencing rules. So severe sepsis may be present on admission, but the diagnosis may not be confirmed until sometime after admission. So what does this mean? Sometimes the patient comes to hospital already having a severe sepsis, but the doctor may not immediately write severe sepsis. Lab results or clinical symptoms may confirm it later. So what is the coding rule for this case? If the provider later confirms that the severe sepsis was present at the time of admission, so it should be coded as present on the admission itself, even though the documentation appears later. So if the documentation is not clear whether severe sepsis was present on admission, then the provider should be queried. So why query? Because coding severe sepsis depends upon the timing. Was it already present when the patient arrived, or did it develop? Did it develop during the hospital stay? So if the chart does not clearly state this, coders must query to avoid the wrong sequencing. So example of when to query. So documentation shows patient admitted with pneumonia. So severe sepsis noted on day 2. So but it is unclear whether symptoms existed before admission. So coder must ask, was severe sepsis present on admission or did it develop after admission? So this is the coding rule. So if the infection associated hemolytic uremic syndrome, that is HUS, with severe sepsis, so you have to assign the infection related coding causing hemolysis or thrombocytopenia or acute kidney failure. So when HUS occurs with severe sepsis, special coding rules apply. Like this guideline gives a specific sequencing instructions which diagnosis takes priority, so how to code both the infection and organ dysfunction. So not all such situations follow the same sequencing rules. So HUS is one of those special cases where you must check the official guidelines to avoid the error. So POA, the presented on admission, affects the DRG assessment and as well as the severity level. So accuracy is most important. So timing of diagnosis does not always equal timing of disease. So this is why you have to understand the clinical context. So this is for today's session. I hope the session has helped you. So in the next session, you will be learning the continuation of this ICD-10-CM coding guidelines for chapter 1 of ICD-10-CM. Thank you.